In this lesson, we will look at the diagnosis of central nervous system infections. Infection of the central nervous system is probably one of the most serious infections that require early diagnosis because of the morbidity and mortality rate associated with this disease. Therefore, for this lesson, read the opening case study and assess the clinical findings presented. Review your notes on body fluids and try to remember the characteristics of normal body fluids and what types of abnormal findings you would expect in bacterial, fungal, or viral infections. So the objectives for this lesson include being able to describe the characteristics of a normal cerebrospinal fluid, or CSF, trace and explain the portals of entry resulting in meningitis, meningoencephalitis, and intracranial mass lesions. Explain how the chemical and cellular composition of the CSF can be used as an aid for early detection and diagnosis. Using the physical, chemical, and cellular features of a spinal fluid sample, differentiate bacterial from fungal, tuberculous, or viral types of meningitis. Explain the relationship between the causative agents and the age of the patient. And for each of the following organisms, describe how the infectious agent caused the disease in different patient groups. Be able to differentiate the suspected agent from other species within the respective genera. Describe the isolation and identification procedures to be performed. These organisms we have covered previously include Streptococcus pneumoniae, Streptococcus agalactiae or group B streptococci, Listeria monocytogenes, Neisseria meningitidis, Haemophilus influenzae, Escherichia coli and other enteric organisms, the fungus Cryptococcus neoformans, and the parasite Toxoplasma gondii. As I mentioned previously, although I would be mentioning certain information or giving you certain information with regards to fungal and parasitic agents, these are not going to be included in your exam since you have a separate course in mycology and parasitology. So to begin, let's look at the opening case study of the 3-year-old male with a recent history of otitis media brought to the emergency room because of fever and lethargy. He had no rash and his vaccination history was up to date. His complete blood count showed leukocytosis with shift to the left and toxicity. Blood and CSF cultures were drawn. Cell count, CSF protein, and glucose levels were also requested. So, as you go through the lesson, look and think about these few points to consider. Why is it important to determine the age group, population, and immune status and history of the patient? What is the significance of the presence of rash in this type of infection or the absence of rash in this type of infection? What predisposing risk factors contribute to the pathogenesis of this infection? How would you correlate the laboratory findings with the possible etiology of the infection? Why are the direct smear findings critical in the presumptive diagnosis of this infection? And think of other points to consider as you review your lecture notes and listen to the lecture presentations. The cerebrospinal fluid has three main purposes. One is to protect the brain and the spinal cord from sudden pressure changes. Secondly, to maintain a stable chemical environment. And three, to remove cerebral metabolic waste products. So to start, let us review the components of the central nervous system and the flow pattern of the spinal fluid. Review the CNS structures as they relate to the formation and circulation of the spinal fluid. Remember that the meninges, the structure that surrounds the exterior of the brain and the spinal cord, has three membranes: the tough dura mater, the spider web-like arachnoid membrane, and the delicate pia mater. The space between the pia mater and arachnoid membrane is called the subarachnoid space. The CSF is produced at the choroid plexuses in the ventricles of the brain, and each day the brain produces about 400 to 500 mL of spinal fluid. Entry of microorganisms into the central nervous system occur via several ways: respiratory, auditory, bloodstream, or direct entry from adjacent sinuses and other neighboring locations. Bacterial infection of the leptomeningeal space can occur from a distant focus via the bloodstream or hypnogenous portal, or by direct invasion from a contiguous focus of infection, such as mastoid or paranasal sinuses, or following neurosurgical procedures or trauma. Most commonly, infection or colonization of the respiratory tract may be followed by invasion of the bloodstream from a respiratory focus and seeding of the meninges. Once in the spinal fluid, bacteria may replicate, release bacterial components, and cause an inflammatory reaction. Infection of the central nervous system, therefore, is probably one of the most serious events that require early diagnosis because of the associated mortality rate. Therefore, examination of the spinal fluid is a very important diagnostic tool to determine infection and the cause of the infection. In addition, CSF analysis can reveal the presence of tumor, neurological disease, leukemia, and many other conditions. During the past 2.5 decades, and we have talked about this before, the epidemiology of meningitis in young children has changed significantly due to the introduction of vaccines against Haemophilus influenza type B. We talk about this when we discuss epiglottitis as a devastating event caused by Haemophilus influenza type B, but that has been prevented due to the introduction of vaccine. This organism, prior to the universal immunization of infants, was the leading cause of meningitis among children 1 to 6 years of age. More recently, in the United States, Streptococcus pneumonia has become the leading cause of bacterial meningitis among children younger than 5 years old. Nevertheless, the overall mortality rate of CNS infections is between 20 to 30%, 5 to 10% in children, and 10 to 20% among neonates. Among those that survive, 25 to 50% will develop some form of sequelae or post-infection complication. 15% will suffer from language impairment. 10% will suffer from hearing difficulties. 10% mental retardation. 3 to 7% motor abnormalities. And 2 to 8% will suffer seizures. I believe I have mentioned this before in other lectures that my daughter did suffer from meningitis when she was 3 years old. And fortunately, she did not have any form of sequelae, except perhaps for some hearing difficulties, and that is selective hearing difficulties when she reached the age of 13. She can't hear me when it's time to clean up her room or help with the dishes. Infection, like many others, results from the complex interplay among the host organism and the environment. So let's take for a moment a look at the host pathogen relationship, starting with the host risk factors. Host risk factors that predispose to infection may include extremes of age, the very young and the very old, nutritional and immunological status, comorbidities such as alcoholism, diabetes mellitus, malignancies, renal failure, head trauma, and neurological procedures such as surgery. Okay, now let's take a look at bacterial structures that play a role in the host pathogen relationship. Structural components of the organism, such as capsule, pili, and fimbriae, that mediate adherence to respiratory tract epithelial cells, play an important role in meningeal infections. Additionally, the bacterial capsule, as we know, can resist neutrophil phagocytosis and complement-mediated bactericidal activity, thus enhancing survival in the bloodstream. With regards to our host defenses, these include the presence of mucosal immunity mediated via immunoglobulin A or IgA antibody, complement activation, and the presence of organism-specific antibodies. The likely causative agents of bacterial meningitis depend on the age of the patient, as you can see here, and on host factors such as immune status, presence of a CSF leak, or presence of a foreign body, such as ventriculoperitoneal shunt. So you need to take this in consideration in assessing what the possible agent of bacterial meningitis would be present. And I believe that this table may look familiar to you all. Among the community-acquired CNS infections, neonates aged less than 1 month old, from 1 day to less than 1 month old, are most susceptible to group B streptococci infections. Escherichia coli and Listeria monocytogenes are also not uncommon isolates. This occurrence is usually due to the increased colonization of these organisms in the mother's cervical canal during childbirth that allows infection in the newborn. In neonates older than 2 months after 6 years of age, opportunists in the upper respiratory tract, such as Streptococcus pneumoniae, Haemophilus influenzae, and Neisseria meningitidis are most common. These inhabitants in the upper respiratory tract of normal individuals set of infections in the segment of the population at the time when the maternal antibodies have declined significantly, and at the same time, the child's own immune system has not fully developed. This leaves the child without any protection against infection. And this is, I would have to say, the most vulnerable age of the individual children, where they are most susceptible to upper respiratory and lower respiratory tract infections due to the same group of organisms, as well as the complication of an acute meningeal infection. Now, as the child ages and the immune system develops, the incidence of infections in this patient group decreases. Streptococcus pneumonia, Neisseria meningitidis, and Listeria monocytogenes again will show up and cause infections in two populations, two groups. Neisseria meningitidis will show up again among teenage groups and college students and military recruits. Streptococcus pneumoniae infection occurs for the second time in the elderly adults, especially those who are chronically ill and alcoholics, and Listeria monocytogenes in the elderly and those who undergo chemotherapy. Other agents of CNS infections may include Staphylococcus coagulase negative staphylococci in patients with CSF shunts. Post-neurological surgery patients may become infected with Staph aureus, Pseudomonas aeruginosa, and other enteric organisms. Let's stop for a moment and do a case check. Here are some points to consider as we go through the opening case study. First, knowing the age group or population and the patient's immunization history. Why is this important? So let's take a look at our opening case. It's a 3-year-old child, which means that, as we have just talked about, Streptococcus pneumoniae and Neisseria meningitidis and Haemophilus influenzae could be the possible agents. Now, the patient is up to date with his immunization history, and therefore Haemophilus influenza could be possibly ruled out. The significance or presence or absence of rash in suspected CNS infections. We have learned that Neisseria meningitidis in the course of the disease may cause a rash in patients. And so the absence of a rash may also rule out possibly Neisseria meningitidis. Lastly, the predisposing risk factor that may have contributed to the pathogenesis of the infection. It was mentioned that the 3-year-old child had suffered from unresolved otitis media. And what is the most common cause of otitis media is Streptococcus pneumoniae. So this is how you may use this information in possibly ruling in or ruling out organism from a long list of possible cause of the CNS infection. So let's continue. So let's continue reviewing the CSF bacterial infections and its agents, and reviewing the characteristic morphology of these agents, starting with Streptococcus agalactiae, or Group B Streptococci, which is a gram-positive cocci in chains that is often isolated from the rectal or vaginal cultures of asymptomatic pregnant women. Early onset of GPS, or Group B Streptococcus disease, usually occurs within the first 24 hours of life and is not commonly associated with meningitis, only about 5 to 10% of the cases. Late onset disease, which typically occurs at 3 to 4 weeks of age, which ranges about 7 to 89 days, commonly manifests as a cold bacteremia or meningitis, which shows about approximately 30% of the cases. So approximately 50% of survivors of either early or late onset meningitis have long-term neurologic sequelae. Again, review the identification characteristics of Group B streptococci. While aerobic gram-negative bacilli, such as Escherichia coli, is probably the most common among the enteric bacilli, but Klebsiella species, Acinetobacter baumannii, Pseudomonas aeruginosa, Serratia species, and other enteric bacilli can also cause meningitis. Now, most strains of E. coli that cause meningitis possess the Ki antigen. So a gram-negative rod from a 2-day-old infant should be suspected with any of the enteric bacilli, enteric organisms, but most commonly Escherichia coli. In addition to neonates, older adults, patients with head trauma, or those who have undergone neurosurgical procedures are also at risk of meningitis caused by these organisms. This is an image of congenital listeriosis being suspected. As you can see here, this is a gram stain smear of the amniotic fluid showing purulence white blood cells and gram-positive small non-spore foreign bacilli typical of Listeria monocytogenes. As you may recall, Listeria monocytogenes is a gram-positive non-spore forming, they're small rods, okay? Infection by this organism is usually seen in pregnant women, neonates, older adults, alcoholics, and those with impaired cell-mediated immunity. Outbreaks of Listeria infection have been associated with the consumption of contaminated coleslaw, milk, ice cream, and cheese. So if you're pregnant, you have been recommended or suggested to you to avoid this kind of food for possible contamination of this organism. Patients with meningitis caused by Listeria, unlike other bacterial infections, have low CSF leukocyte counts with predominance of lymphocytes. Looking at this gram-stained smear, what you should be looking at closely are the bow tie, okay? The diplococci, gram-positive diplococci, characteristic of Streptococcus pneumoniae. Look at how these organisms are paired. If you use kind of stretch your imagination, this is what you're looking for. They are diplococci that are arranged end to end. And I will show you how to tell the difference between Streptococcus pneumoniae diplococci versus gram-negative diplococci of Neisseria species. So let's talk about Streptococcus pneumoniae. This is the most common cause of meningitis in adults and in children. Of more than 90 serotypes, only a few serotypes accounted for most cases of invasive childhood pneumococcal infections in the United States before the implementation of routine immunization among infants with a heptavalent conjugate vaccine. Patients with sickle cell anemia, um, patients without spleen who had gone splenectomy or a splenia, malignancy, malnutrition, those with chronic renal or liver disease are more likely to develop serious pneumococcal disease. So here is a direct smear of a CSF from a high school student showing clusters of gram-negative intracellular diplococci consistent of Neisseria meningitidis. As I mentioned before, Neisseria species that includes Neisseria meningitidis, Neisseria gonorrhea, and other Neisseria species. They are gram-negative diplococcus. Now, if you look at the organisms real closely on this slide, unlike Streptococcus pneumoniae, where they're diplococci that looks like a bow tie because they attach end to end, Neisseria species are they're facing each other. That's why they are called the kidney bean shape. And to me, they look like hamburger buns. They look like a Big Mac. So that's how you should be able to differentiate the intracellular and even extracellular diplococci of Neisseria versus Streptococcus pneumoniae. You look for the hamburger bun or Big Mac shape of Neisseria species. Neisseria meningitidis is classified into 12 serogroups based on antigenetically distinct non-cross-reactive capsular polysaccharides. Serogroups B, C, and Y account for most cases in Europe and in the United States. Several clusters of serogroup B, meningococcal disease, have occurred in college campuses in the United States, while disease caused by serogroups A and C occur in epidemics. Once again, this is the direct smear of a CSF from a child showing gram-negative pleomorphic coccobacilli characteristic of Haemophilus influenzae, which was previously the most common cause of bacterial meningitis and other respiratory tract infections, especially in young children. Most cases were caused by the capsular type B strains. And since the adoption of the routine use of conjugate vaccines against HIV, there has been a marked reduction in the number of cases of H. influenzae meningitis. In developing countries, however, with limited vaccine coverage, it continues to be an important cause of bacterial meningitis. As I mentioned previously, other bacterial agents may include gram-negative bacilli, such as those that you may find in post-traumatic sources. So here is a direct smear of a post-traumatic acute bacterial meningitis showing encapsulated gram-negative bacilli typical of Klebsiella pneumonia. Others may include Staph aureus, as I have mentioned previously, particularly in post-surgical surgery patients that may lead to brain abscess, Pseudomonas aeruginosa, and other enteric organisms in patients with head trauma, particularly in accidental head trauma. Remember that other agents of CNS infections may include, and this is where coagulase negative staphylococcus may become significant in patients with CSF shunts. Why? Because coagulase negative staph is a normal skin flora that may eventually colonize the shunt. Briefly, other bacteria that involves the CNS that may cause chronic meningitis may include Mycobacterium tuberculosis and other non-tuberculous mycobacteria, the spirochetes, Treponema pallidum, Borrelia burgdorferi, Borrelia recurrentis, Leptospira, and certain parasites and fungal agents. So the next few slides, I'll just, as a matter of completion, will show you some images of some of these agents. So those with immunosuppression may become susceptible to yeast infections such as Cryptococcus neoformans and Coccidioides immitis. You'll see the budding yeast cells on the left, Cryptococcus neoformans. On the right, what you're looking at is Naegleria fowleri, an uncommon but has been fatal type of CNS infection. Naegleria fowleri is a free-living amoeba. They're found in freshwater lakes and streams, and it is a common cause of acute amoebic meningoencephalitis. Individuals who become infected are those that have had history of swimming or bathing in infected waters. Diagnosis is made by finding the model amoeba in wet mount preparations. And the thing with Naegleria fowleri infections is that survival rate, mortality rate is close to 100%. Here are additional images of Cryptococcus cells in meningeal patients. Cryptococcal meningitis in a partially immunocompetent patient on the left, and on the right you have cryptococcal meningitis in an immune suppressed host showing numerous yeast with few inflammatory cells. Here's an image of a parasite, Toxoplasma gondii, that is involved in serious CNS infections, and during recent years had been identified more often, particularly among HIV-infected patients. Among viral agents, herpes viruses that include herpes simplex virus, Epstein-Barr virus, and cytomegalovirus. Varicella virus are the cause of the most common viral meningoencephalitis infections. And in cases of what we call aseptic meningitis, lymphocytes are predominantly present, and rarely that you will find organisms in any of the blood smears or in the stain smears. I would like to spend the last few minutes in the laboratory diagnosis of infections of the central nervous system. The CSF is usually obtained by lumbar puncture. It is a routine practice to collect 3 tubes of CSF, about 1 to 5 milliliters per tube. The first tube is designated for chemistry, the second for microbiological study, and the third for cell counts and differential. Because of the high mortality and morbidity associated with CNS infections, CSF samples must be processed quickly. This is one of those what we call SAT procedures. particularly Streptococcus pneumoniae, because it autolyses, which means it kills itself. Haemophilus influenzae and Neisseria meningitidis also do not survive in the environment for a prolonged period of time. As soon as it is received in the laboratory, the CSF must be centrifuged to obtain a sediment for direct smear and culture preparation. Routine cultures such as sheep blood agar or blood agar plates, chocolate agar, and McConkey agar are inoculated for primary isolation, and direct smear is gram stained for microscopic examination. Let's look at the characteristic findings in the spinal fluid in cases of meningeal infection and compare this with a normal CSF. A normal CSF is a clear, colorless fluid, and it is sterile. In normal adults, the CSF volume ranges from 90 to 150 ml. The protein level is between 15 to 45 milligrams per dl, and the glucose is about 40 to 80% of the blood level. In normal adults, the CSF contains 0 to 10 leukocytes per microliter with a differential count of about 60 to 80% lymphocytes, 10 to 40% monocytes, and 0 to 15% neutrophils. Compared with adults, normal newborns have higher CSF concentrations of proteins, glucose, and cells, which amount to about 30 leukocytes per ml with a greater percentage of monocytes and neutrophils. So these are some stuff that you need to take in consideration. So in abnormal findings in acute bacterial meningitis, we can use these non-specific indicators in the diagnosis of meningitis. The spinal fluid is normally clear, as we mentioned before, so always note the color and presence of turbidity in your report. Turbidity usually indicates the presence of cells in the fluid. The CSF protein level and increased total protein value is the most common non-specific but reliable indicator of CNS disease. Increased capillary permeability, biosynthesis of gamma globulins, and decreased absorption are factors that have been associated with increased CSF protein. With CSF glucose levels reflect that of plasma concentration. Therefore, CSF and serum concentrations are needed for proper interpretation. Decreased CSF glucose level usually indicates an infection, such as bacterial, tuberculosis, or fungal meningitis. This is attributed to increased glucose utilization by the leukocytes and the bacteria or the CNS tissue that is present in the fluid. Look at the cell count. The leukocyte cell count is usually increased during bacterial infections, with neutrophils as the predominant cells found. And compare the different cell types found in each type of infection as you consider the CSF findings in the next slide. Here you compare the characteristic findings using the same parameters in viral and fungal meningeal infection. What do you notice? In viral infections, usually the spinal fluid is clear, the total proteins may be slightly increased, Glucose may be even normal. The cell count may be increased predominantly, as we mentioned, with lymphocytes. There will be no bacteria seen on the gram stain. In fungal meningitis, the spinal fluid may remain clear. Total protein may be moderately increased. Glucose may be usually moderately reduced. Cell count would be increased predominantly with lymphocytes. And if you get lucky, may find encapsulated yeast on the gram stain on the direct smear. So let's do the last case check, correlating the lab results. What is the appearance of the CSF? What's the glucose and total protein levels? The cell count and what type of cells predominate? Are they neutrophils or lymphocytes? And of course, the direct gram stain smear findings. So make sure that you correlate these findings. Go to hematology to check the cell count. And most important of all, as I mentioned, it's the direct gram stain results. Review the microscopic morphology of the pathogens we have previously discussed. So what are the important points to remember? Host-related risk factors and virulence factors associated with specific pathogens. Very helpful information, the age and the clinical history of the affected population. What does the spinal fluid look like? Look at the characteristics of the spinal fluid, the non-specific indicators, glucose, proteins, cells, and the characteristics of the microbial agents you find on the direct smear preparations. And hopefully you understand why I am so big on microscopy. The microscopic characteristics of your organisms on the direct smear will lead you to the proper identification of the etiologic agent of the disease. This is the end of this presentation.